You want me to start? Okay. Good morning, everyone. It's a pleasure to be here together for this demonstration on driving pressure. My name is Ewan Goligher. I'm from the University of Toronto, and very with Dr. Luigi Camporota.
Good morning, everyone. And I'm Luigi, and I'm work at St Thomas's Hospital in London. King's College London is the university. And shall we start? I think, do you know what I mean by this? This is a bit of water going into a glass. Do you know what has to do with this talk today, or this discussion? Well, if you don't, I'll try and explain and see whether it makes sense. It makes sense to me, but I hope it makes sense to you. So essentially, when we talk about ventilation, we talk about tidal volumes particularly, we look at one size of the equation. The size is this. If you take the analogy of water going into a glass, we'll just say, okay, we want 6 mils per kilo of predicted body weight, which is the amount of water, okay? But what we don't know is what is the size of the glass. We can have the same amount of water in a very small glass, and then what happens? The water comes out and we get all wet and it's a disaster. But at the same time, the same water can go into a larger glass, and that problem will not happen. And so the point of this conversation today is that, yes, so far we've looked at the amount of water, which is the quantity of tidal volume. But now we need to think about what is the right proportion between water and between the glass. So with that thought in mind, let's go through. Now, this is one of the ideas. Do you remember this is the original paper? 2000, groundbreaking, 6 mils per kilo versus 12 mils per kilo. 12 mils per kilo, bad. Some people say 6 mils per kilo, good. You can say the other way. But if you look here, the bottom there, you can see one thing. So these are quartiles of static compliance. So low compliance, high compliance. So small glass on the left, large glass on the right, yeah? And what you can see is the amount of water or tidal volume matters a lot when the glass is very small, but it doesn't seem to matter that much when the glass is very large, when the compliance is large. So one of the ideas is, how do we know that we've got the right amount of tidal volume, or water, you'll get tired of me saying that, compared to the size of the lung? Well, we need to think about scaling it. Not scaling it to predicted body weight, because we've seen it doesn't really matter, but scaling it to the size of the lung. So one of the things we can do is essentially we'll calculate the strain. But strain is very hard, isn't it? How many people measure FRC at the bedside? I can see that we're all in the same boat.
If anybody said yes, we would say we don't believe you.
Show it.
Can't.
Okay, but we've demonstrated very rapidly that FRC is not measured at the bedside. But what is measured at the bedside is one thing. So obviously the strain is the elasticity there. We think about this relationship between compliance and FRC. So the higher the FRC, the higher the compliance. So then we can look and say, okay, we don't measure FRC, but we know that the two are related. So let's measure compliance. Now, if you do that, and we know very well that compliance is tidal volume divided plateau minus PEEP. Now, if you do some advanced mathematics and you just delete those two, you'll just relate that plateau minus PEEP is a proxy measure of strain. So plateau minus PEEP is the subject of what we are talking today. So driving pressure. Now you can see that with one measure, we have an idea whether the amount of water is proportional to the glass, whether the tidal volume is proportional to the size of the lung. And so that's that again. And we know very well that there are some thresholds above which the odds ratio of death increase. That threshold is said to be 15. And now, I mean, Ewan will discuss about this, but this is not a target. This is a threshold. So it's not something that you want to set at 15. This is your upper level of threshold. And so this is what has been confirmed again, and this is what the Ewan will say. Essentially, driving pressure and respiratory rate, they seem to be related to mortality. Now, this is quite interesting. I think that will demonstrate the difference between setting the ventilation based on tidal volume and looking at driving pressure. Look, this is a lung safe study. You can see on your left-hand side is big lungs, medium lungs, small lungs, okay? And now the doctors at the bedside set the tidal volume at 8.5 mils per kilo predicted body weight. Who is happy with that tidal volume? No one. Would you be arrested in your unit if you use that? I think we would get upset. Yeah? Okay. Now you've got another group, 7.5. Better? Yeah? Yeah, everyone happier. What about if I told you that this one here requires a driving pressure of 7 and that one requires a driving pressure of 17? Where would you be happy now? Or the other one? So you can see we concentrate on the water, we don't concentrate on the glass, and this will give us a proportion. So now you can see the picture is completely flipped, and now we're not happy with the left-hand side. Okay. Ewan, I think this is your...
Yeah, so I think the kind of critical message that we want to get across here is that driving pressure is a way of personalizing the appropriate tidal volume for the patient. We talk a lot about personalized medicine, we talk a lot about precision medicine, and the basic idea with the driving pressure is that it gives us a way of personalizing what tidal volume is appropriate for the patient. So when I'm on rounds in the ICU with the residents, and I always teach them that when I see a ventilated patient, with respect to the mechanical ventilation, there are 3 questions that they should ask themselves. The first question is it adequate? The second question, is it safe? And the third question, is it necessary? And what we're discussing here is how do you answer this question, is the ventilation safe? So traditionally we've said, tidal volume 6 mils per kilo, ventilation is safe. And we all know that's probably not true. And what we really want to drive home to you is what the appropriate tidal volume is for a different patient depends on their respiratory mechanics. And Dr. Camporota has given you some data to show that, and I want to show you some of the work that we've done to really drive that home. So in the last slide, we saw some data about the H and L phenotypes in COVID, which for some reason was incredibly controversial. But these are data from the original higher versus lower tidal volume trials that quite convincingly demonstrate the existence of H and L phenotypes. So what do I mean? So here on the x-axis, we have elastance, which is, of course, the inverse of the compliance. And it's the elastance normalized to the height. So we're basically taking into account the fact that lung size depends on the height of the individual. And normal value for elastance would be less than 1. And by the way, this is true for all mammals, all the way from mice to elephants. They all have a normalized elastance of less than 1 centimeter of water per mil per kilo. So that just speaks to you about the fact that these measurements tell you something real about the properties or the size of the lung available for ventilation. So a patient with low elastance would have a large FRC, and a patient with higher elastance would have lower FRC. And what we're doing here is we're looking at the distribution of tidal volume and the distribution of driving pressure according to elastance in patients randomized to a higher tidal volume in blue and a lower tidal volume in red. So no surprise, the patients randomized to higher tidal volume in these original tidal volume trials, those patients had a higher tidal volume. And what's notable is that the greatest separation is seen at low elastance. So whereas with patients with higher elastance, you have less separation in tidal volume between groups. By contrast, if you look at the driving pressure here, it's very similar in patients with low elastance, and you see a large separation at high elastance. So if it's the case that the tidal volume is the thing that really matters for protecting the lung, then you should have pretty much the same mortality benefit across elastance, or maybe even the greatest mortality benefit when elastance is low, because that's where the separation in tidal volume is greatest. But if it's the case that the driving pressure is what really matters, then you would expect to see less mortality benefit at low elastance and greater mortality benefit at high elastance, because that's where the separation is being obtained. And so the question is, can we use elastance or its inverse compliance to decide how to personalize the tidal volume? And the answer, using data from these original lower versus higher tidal volume trials, is very much, it seems to be the case that yes, the treatment effect of lowering tidal volume depends a lot on what your elastance or your compliance are. So we really do have these H and L phenotypes, so to speak. Let me explain what I mean. So here on the y-axis now, we have the probability of death. And on the x-axis, we have the elastance here again. And what you can see is the risk of death in patients randomized to higher tidal volume is shown in the blue again, and the risk of death in the patients randomized to lower tidal volume shown in the red. And you can see when the elastance is low, the mortality is very similar between higher and lower tidal volume. It didn't matter whether your tidal volume was 12 or 6. But when the elastance is high or the compliance is low, you've got very large separation in mortality. So all of the benefit from lowering tidal volume correlates with how much you're actually lowering the driving pressure. And so this sort of gives us very strong reason to think that we can personalize the tidal volume wisely based on the driving pressure. So if you're asking yourself, is the ventilation safe? Then the answer is it depends on the compliance or the elastance. And that determines what the right driving pressure is. So I hand it back to Dr. Camporota here.
So if we were to think about this, just to summarize 1 second, so maybe we can choose a hybrid approach. I mean, that's what I do. We start with 6 mils per kilo. You need to start somewhere. Then you measure your mechanics. Then you measure your driving pressure. If your driving pressure is low, that's fine. You can still modify your tidal volume, and we'll see that in a second. Or if your driving pressure is high, now you know 6 is too much, and we need to think about lowering down. So you can choose a hybrid approach because you need to start from somewhere. And I think that's probably a pragmatic way. But I want to show you a couple of problems with driving pressure. Now, what do you notice? This is a low flow curve, as you know. So you've got pressure on the x-axis and volume on the y-axis. Can anyone spot a problem with this? I'm conscious that at the back you might not see it, so I assume you've all seen it and agree with it. Otherwise, we'll illustrate in a second. Can you see a problem with that low flow curve? Does it look normal? We'll see whether I can illustrate it. You were going to say something? Oh, no, okay. So, yeah, you would probably say it looks okay, yeah, that very tight. But there is a problem there. Let me show you if I can. Look, until we get, so this is starting at 0 up to 35. But you can see there is no volume at all up until the pressure is 15, okay? So then after 15, you've got rapid rise in compliance, because it's basically the volume divided by the pressure. And so this is a problem, because if you were not aware, let me show you this. So this is the airway opening pressure. So below this point, there is no pressure and volume inflating the lung. And above this point, the lung completely opens. But not because of recruitment, but because the small airways open, so they admit flow and volume. Now look at the difference. If you were not aware of this, you would assume that the driving pressure is 35 minus 0, yeah? Because you start from 0, you go to 35, you've got 650 milliliters of volume. So you divide it by 35 minus 0, so the driving pressure being 35, and you get a compliance of 18. Whereas if you take that airway opening pressure into account, then now the true driving pressure to the lung is not 35 minus 0, but 35 minus 15. So that means that you need to take into consideration, in terms of your safety of the driving pressure, you need to ask yourself, is there an airway opening pressure that might affect my calculation, and therefore my calculation of the right tidal volume? Does it make sense, this one? Yeah? Okay, so, yeah. The other thing, can I ask one question? Who uses volume control ventilation? Okay, who uses a pressure control ventilation? Okay, so this is another issue. And do you use volume control? Pressure control, yeah. We use the same. But look at this. I tried my best to draw this waveform, so if it doesn't work, apologies. But let's pretend this is a flow curve, yeah? And now you've got a tidal volume of 420 and a driving pressure of 18. We said 15 was an upper threshold. What would you do? Who would change the tidal volume to fit to the driving pressure? Who is happy with it? Who doesn't care one way or the other? Yeah, okay. Assume that we all care, but look at this. Look at this flow. The inspiratory time is very, very short. So now, if I change the inspiratory time, now I've got the same tidal volume, but on a driving pressure of 12. So the question is, I suppose what we're trying to say in these two demonstrations, they do calculate driving pressure, but be aware that something related to patient characteristics like airway opening pressure or the way we set the ventilator in terms of flow, time, etc., can affect your driving pressure. So take that into consideration and you can optimize the ventilation before you can make some decisions.
Sorry, just to go back. So this is in pressure control?
Yeah, pressure
okay.
control. Yeah.
And so when you're measuring driving pressure and pressure control, you're taking it as the peak minus the PEEP? Is that?
Yeah.
Okay.
That's
maybe some people might still do a kind of end inspiratory hold.
No, that's a good point. So this is the problem when you don't do a plateau pressure. When you assume, sorry, I missed that passage, that step. This is very important. Most people assume that once you're in pressure control, plateau is equal to peak. That's not the case. So either you do a proper plateau pressure, or you just look at the flow waveform and just make an assessment based on that. But this could be a problem with observational studies when you don't have a proper plateau and you assume the two being roughly the same. Thanks, Ewan. Do you want to talk about this? Or yeah, are you happy so far? Any questions so far? Because we are going to do another situation here. Because now what we have done, we've decided that whatever that was, that driving pressure was too much. That tidal volume was too much. And now we've got a problem, because if we decrease the tidal volume and we've got a problem with the CO2, what do? We need to change the rate, don't we? The question is, at some point, and that's what I meant by this person trying to balance the two things, is it better to give a little bit more driving pressure? Or is it a little bit better to give more respiratory rate? The answer depends on the patient. I'll give you an example. Now, let's plan we've got patient A. driving pressure of 10. Sorry, that square should have been a dot, but never mind. Driving pressure of 10, tidal volume 400, respiratory rate of 30. Who is happy with this? Maybe you're happy with the driving pressure? Yeah? You're not very happy with the rate? And now we've got another situation. What do you think? Tidal volume 600. Ooh. Driving pressure 15. Rate of 10. So now I'm guessing you're happy with the rate, but you're not so happy with the driving pressure. So what shall we do now?
Bring down the driving pressure.
It depends, but this is the patient. Okay. How would you work that out? Sorry.
It depends on the patient mechanics, on its compliance and its resistance. So I look for time constant and look for the best expiratory time and adjusting that way.
You want to make sure that actually the 30 is filling and empty the patient properly. We don't know. Okay. So there is another alternative that comes from some analysis of randomized trials, that you can see that little formula at the top. You multiply the driving pressure by 4 and you add respiratory rate. The higher that number, the worse it is in terms of outcome. Now, if the mathematics doesn't fail me, these two patients are exactly the same. So you can use one or the other, which will depend, as you say, on the mechanics. But this might give you an idea that, for example, if this second number is better than the first one, everything else being equal, so entitled CO2, PA CO2, everything else being equal, you would go for B rather than A. If that was higher, you probably would go for A or B, over B. And if the two are the same, what would you do? I let the nurse choose, because they're always right. So in that situation, it depends which one makes you feel more comfortable. But this is a little bedside easy. It's a bit similar to mechanical power without the computational difficulties. Any questions? Anything you want to say about this?
Yeah, I mean, I think this is complicated, and I personally am uncertain how to balance the relative effects of increasing rate and lowering driving pressure. One thing I'm personally persuaded of is that if the driving pressure is 15 or lower, the risk of VILI is probably already very low, and it probably doesn't matter that much. That would be my personal take from the literature. But this comes from a very important paper by Costa and Amato that seem to highlight that respiratory rate probably does matter. But once the driving pressure is as low as 10, it's not clear to me that a high frequency is going to do much damage if the intrinsic tidal stress is already very low. So I would say there's probably some variability in interpretation here, and
there is.
Yeah.
The other thing is sometimes high respiratory rate is not really great for gas exchange, based on what you were saying, your dead space fraction. So those are just examples to make my maths easier, but obviously you can extrapolate that. Yeah.
The second example, is there any reason you couldn't? The second example, you have a borderline high driving pressure, but you have plenty of ventilation, so why not just decrease your driving pressure and have the benefits of both that and the slower rate?
Yeah, absolutely. And that's what illustrates, that will give you the opportunity to say, actually, these two modes of ventilation, they're very similar overall, because what you lose in driving pressure, you gain in rate. And both of them being important, you can say, where do I find the balance? Do I go stay here and it really or do I go over here? And that will give you an additional information. And as we all know in medicine, there's not one number, but just several things together, they'll say go in one direction or the other.
As all we know that it is rather complicated to judge which the left side or right side. Do you think correlating these findings with the resulting blood gases could give us more relief to choose. If the first choice give me better blood gases rather than minimal changes in the driving pressure, I will buy this, because at the end of the day we are looking for better gas diffusion and better blood gases for the patient.
Sally, if blood gases also you mean carbon dioxide, dead space, then you can choose what is best. I think the point for us today is to discuss a few little things that you can put in your recipe book and say, actually, considered everything, that's what I would go for.
Yeah, the one thing I would say on that point is, to me, the blood gas answers a different question. The blood gas answers the question, is the ventilation adequate? There's lots of data to suggest it tells us nothing about whether the ventilation's safe or not. And so, this is where the driving pressure becomes informative about the question, is the ventilation safe? So the blood gas and the mechanics, we're arguing answering two different questions.
Should we concern the plateau pressure?
Yeah, this is a really important question. So if I could repeat and sort of expand on your question a little bit is, okay, we've controlled the driving pressure, but the plateau pressure is still high. Should we care? And I think the answer is, A, if you're controlling the driving pressure, you're almost always going to be controlling your plateau pressure as well, because the two are so obviously collinear. And B, I think the preponderance of data suggests that the tidal or dynamic stress is more significant than the kind of peak static stress. So provided your plateau pressure is, under 35 centimeters of water, I think the main target should be limiting the driving pressure. Okay, so you guys have been drinking from a fire hose here, and appreciate your attention. So in the last 2 minutes that remains to us, I just wanted to point out the way that this information is important not only during controlled passive ventilation, but also during spontaneous breathing. So one of the big challenges that you have when you're rounding in the ICU is you look at the ventilator, the patient's awake, breathing, and generating a tidal volume of 700 cc's. And the team looks at you and says, oh, are we okay with this? And so the question, how do you answer that question? This is 9 mils per kilo. This is way above what we would normally allow a patient to have on a ventilator. How many of you see a tidal volume like that and are tempted to increase the sedation to try and reduce the tidal volume? Not very many people. Interesting. Okay. So, and that's important because we've been sort of also ingrained to say, oh, what's also really important is getting the sedation off as much as possible. And so there's this tension between managing the sedation and managing the ventilator. And I think this is an area for a lot of ongoing research in our field. But one thing that's actually quite informative and I think quite reassuring is that we have a few ways of assessing what the degree of lung stress and strain is during spontaneous breathing. One of them is to try and measure the plateau pressure and driving pressure during spontaneous breathing. And though often the teaching is that you can't do that, in fact, provided your ventilator allows you to do an end inspiratory hold and pressure support, you often can actually get fairly decent plateau pressure as shown here. If the patient has a very high drive to breathe, if they've got a lot of abdominal muscle effort, it may be very difficult to get a stable plateau pressure. But there are many patients in whom you can get a reasonable plateau pressure. And you can see here, interestingly, the plateau is actually higher than the peak because some of the pressure inflating the lung comes from the respiratory muscle effort rather than from the ventilator. And so this gives you a way of saying, okay, with this tidal volume, is the driving pressure acceptably low? And if it's very, very high, you may want to consider suppressing that patient's drive to breathe by whatever means possible in order to control the tidal volume. Another very simple way of assessing the stress and strain on the lung during spontaneous breathing is to do an end expiratory hold rather than an end inspiratory hold. So here you can see the end inspiratory hold to get the plateau pressure. But here during expiration, if you do an end expiratory hold, you can measure the POC, which is the swing in pressure during the inspiratory effort by the patient. So normally on the pressure time waveform on the ventilator, all you can see are the positive pressure swings with each breath. But if you do an end expiratory hold and occlude the airway, the patient goes to breathe and they make an effort against the occluded airway, and that reveals the magnitude of their underlying respiratory efforts. This is a very simple maneuver that's well validated by multiple groups. And so you can use that to estimate the pleural pressure swing. From that, you can use that to estimate the lung spontaneous breathing. And so, again, these are very simple maneuvers that allow you to decide, is the ventilation safe? Is my spontaneously breathing patient have excessive tidal volume? So I see we're out of time, so I'm just going to stop there and see if there's any last questions before we wrap up.
Can I ask a question to everyone? How many people use this techniques in spontaneous breathing patients, like pressure muscle index, occlusion, pressure? Okay, so it looks like it's getting more common. And as you say, it's one simple maneuver. I find the PMI sometimes it doesn't work with some of the patients, but I think the occlusion pressure is quite reliable, yeah. But they answer different questions.
Yeah, agreed.
Okay, you've been wonderful. Time is over. Enjoy the rest of the day. Oh, you've got one question.
To manipulate the driving pressure, which one is better between the PEEP or reduce the tidal volume?
That's a good question. Do you want me to? Yeah, I mean, in general, I would say the first thing to do is to reduce the tidal volume. That's the simplest thing to do, provided pH permits it. But, adjusting PEEP would also be very appropriate. So it will depend on the patient's condition. But the first thing to do generally would be to change the tidal volume.
Fantastic. Well, you've been wonderful. Time is over. Enjoy the rest of the conference. Thank you.